Hey everyone, we'll get to the interview in just 1 second, but I wanted to mention just a few things. I know you guys are going to have a lot of questions for me, so I'm just going to try to answer some of them. Yes, I did do the mind procedure with Dr. Coppelson. I will be uploading my personal experience with the mind procedure in the upcoming weeks, so be sure to subscribe to the channel so you don't miss any of that. This was entirely my idea. The Breathe Institute did not reach out to me, nor did they financially compensate me for doing this video. I saw it as a mutually beneficial effort, so I suggested it to them. I consulted with Dr. Casey Lee, Dr. Benjamin Walling, and Dr. Coppelson for maxillary expansion, and as you can see, elected for Dr. Coppelson. This isn't about, placing Coppelson on a pedestal over other surgeons. I suggest everyone do your own due diligence. I decided personally to go with Dr. Coppelson because he lined up with what I was looking for and what I wanted to get out of this surgery. I also just wanted to mention that if you're looking for someone to help guide you with your CPAP therapy or your journey in sleep disordered breathing, that is what I'm trying to specialize in. With each passing day, I feel to be in a stronger position, and it's my goal to essentially help people who are traveling a path that I was once traveling. Pretty soon I'll be making my own website where I'll upload patient testimonies so that you can get a better idea. From my experience so far, and I think I've done about hundreds of these at this point, one-on-one, I think everyone walks away with something. I will continue, of course, to upload all of my understanding and knowledge to this channel, so there is no need to pay for anything. There will be a couple more interviews coming out on my channel quite soon that I'm quite excited for, and I think that the audience is going to find a lot of value in. So again, make sure you subscribe. It helps my channel a lot. I'll try to answer as many questions as you guys might have in the comments section, but just bear in mind that in the upcoming weeks, I will be releasing more content centered on maxillary expansion and particularly my personal experience with it. And Dr. Coppelson and I are also going to go over some of the objective sort of criteria that can be reviewed when determining whether someone could benefit from something like maxillary expansion. Do you want to just start by telling everyone where we are, how you got here, what is this place?
Yeah. So this is the Breathe Institute in Los Angeles, California. We're a airway, sleep, and breathing focused practice. Multi-specialty, so we have an ENT sleep surgeon by the name of Dr. Suresh Zaghi, one of our founders. I am Kevin Coppelson. I'm an oral and maxillofacial surgeon, specialty trained in advanced maxillofacial surgery, where I concentrated on corrective jaw surgery, distraction osteogenesis, skeletal expansion. We have lots of other providers, including pediatric dentists and lots of myofunctional therapists. So what we specialize in here is trying to not just treat sleep apnea, but hopefully cure it, give people better quality of life, longer lifespans and health spans, and trying to do things the most effective and cutting edge ways. That will sometimes imply obviously new technologies and tools and things like that, but also how you bring a team together. So how did I get here? So I'm an oral and maxillofacial surgeon, started out in dental school, fell in love with oral and maxillofacial surgery. I thought it was really cool. When I saw people, getting surgeries on their facial bones, I was like, that's something I want to do. In fellowship, I really fell in love with corrective jaw surgery. So that's orthognathic surgery. When we do it for sleep apnea, it's called maxillomandibular advancement surgery, where you're basically bringing the jaws forward and doing other orientational things like counterclockwise rotation and fixing symmetry issues and things like that. So I knew that's the type of surgeon I wanted to be. So I did fellowship to become even better and figure out the best ways of doing these things so that I could provide the highest quality care. After fellowship, I moved straight to LA, started working at the Breathe Institute, and founded our oral and maxillofacial surgery department here called Breathe Max. And since being here, I've really focused on trying to provide all the spectrum of oral and maxillofacial surgery tools that can be helpful in treating and hopefully curing sleep apnea. So lots of corrective jaw surgery, maxillomandibular advancement surgery like we talked about. I do a lot of maxillary expansion. That's where you widen the upper jaw, and actually the way we do it now, it's more actually mid-face expansion, where you get three-dimensional expansion of not just the palate, but also the nasal cavity volume. The technique that we do here is a very minimally invasive approach. It's called MIND, which stands for minimally invasive nasomaxillary distraction. I also do mandibular distraction, so that's where we widen the lower jaw, similar to the way we widen the upper jaw, down the middle using a distractor, and then SFOT, which is surgically facilitated orthodontic therapy, where we're actually doing more dental alveolar expansion to assist with certain cases that are going to require orthodontic expansion for airway or periodontal or orthodontic reasons.
So, what is this procedure, the MIND procedure? How is it different than other maxillary expansions? Is there a difference between doing the 3D thing versus just standard?
Yeah.
I think it's called Le Fort 1.
Yeah.
How do you arrive at it?
Yeah.
Stuff around that.
Awesome. So, the MIND procedure is different than traditional surgical maxillary expansion cases, mainly by the level of expansion that you get. Traditional maxillary expansion surgical cases are based on what we call a two-piece Le Fort 1 osteotomy. This would be a good time to cut to a graphic maybe and show where that cut is. But it's basically a cut that's done horizontally above the roots of the teeth, kind of at the level of the floor of the nose. And so when you expand the maxilla, you're actually only expanding that portion of the maxilla, which is mainly the alveolar process of the maxilla along with the palatal bone. With that, you will get expansion of the palate, which is important for tongue space. And as that palate expands, the hard palate expands, the soft palate will tighten up. So you do get airway benefits. The nasal floor widens. You get a little bit of improvement in nasal breathing from that as well. But it's obviously targeting a small area of a maxilla that is actually, the whole thing is narrow. So if you look at a maxilla, it actually makes up a majority of your midface. And when you're doing a two-piece Le Fort, you're kind of ignoring the rest of it. You're ignoring the rest of the nasal cavity. Another problem with the traditional surgeries is that they are pretty invasive. So to do a Le Fort 1 osteotomy, it's a huge incision, first molar to first molar, big dissection, which just means a lot more brutal of a recovery, lots of facial swelling, kind of like that pumpkin facial swelling that you'll see in patients that have jaw surgery. And it's something that more often than not has to be done in a hospital setting because of all the risks of doing such a big operation. The reason I developed the MIND technique is because I got privy to how we were starting to experience not just the Fort 1 level expansion, but in MARPI cases in young adults, we were getting midface expansion. So we were doing what we call 3D renderings of CBCT scans. So you get a CT scan, which is like a 3D x-ray, before and after in a kid that had a MARPI, and you superimpose those images on each other, and you can see the actual skeletal changes that happen. And it wasn't Le Fort 1 level expansion. These patients were getting true midface expansion. So the entire midface, the cheekbones, the nasal cavity, everything three-dimensionally expands. And that is going to give you a superior airway result because you're still getting that palatal expansion, which gives you more tongue space, tightening of the hard palate, which tightens up the soft palate. But now you're getting three-dimensional expansion of the nasal cavity volume. And let's be real, there's a lot of patients that get filler or cheekbone implants and things like that. So there's a cosmetic component to also widening the midface that I thought was super beneficial. Superior airway results, superior cosmetic results. That's what I was striving for. And to do that in a skeletal immature adult was my goal. So definitely a little bit of tinkering in the beginning to make it as predictable as possible. But now it's kind of locked in. So, as the technology has improved, MARPIs have gotten better, stronger jack screws. We're able to kind of push the threshold on who can get a MARPI and who cannot. But there's definitely a huge benefit to getting true midface expansion as opposed to the Fort 1 level expansion and being able to do it in a minimally invasive technique versus a big surgery with a big recovery that's done in a hospital. The MIND procedure, as you know, something I can do right here in the office most of the time. Some patients, obviously, they just you're very surgery anxious and they just want to be asleep, and we can offer that and do it at a surgery center, at a hospital. But some patients, they don't want to undergo general anesthesia. We can do it right here with a little twilight sedation, or some patients even get it just under local anesthesia. So can numb you up, do it chair side. Recovery is really not that bad. The surgery is done through 3 little small incisions, about 1/2 inch to 1 inch big. And I operate through those little ports. And because of that minimally invasive nature, the recovery is not that bad. You don't get too swollen, and the pain tends to be, easily manageable.
Is it right to say that you were doing the standard maxillary expansions before, and then you kind of transitioned to mind?
Yeah.
And do you do those ever now? Is there like an indication to do those over mind?
No.
By any chance?
So that's a great question. Yeah, I used to do SARPs. I used to do dome. I used to do the traditional ease procedure. That is actually one of the things that maybe inspired some of the techniques I do in mind. It's a little bit different than the paper on ease. I definitely traditionally used to do SARPs, then I switched over to dome because I think there's a benefit to using a bone-borne expander over a tooth-borne expander. Less relapse, less dental alveolar consequences of tooth tipping and things like that. Then when I started doing mind, there were cases where I was like, okay, if this doesn't work, we have the traditional techniques in our back pocket. But now I can't remember the last time I've done a dome or anything like that. It's been years. It's down to a science now how we can successfully do these operations. So is it something that is in my back pocket? Yes, but I haven't had to use that tool in quite some time.
Some people like to say that there isn't a significant amount of evidence to suggest that releasing the pteromaxillary junction is in aggregate somehow better than, let's say, strictly fan-shaped expansions. Is that true? Do we not know? Is there confusion? Is the data just bad? What do we know about that?
I'd say not enough data in general. I would say in general it makes sense to have as parallel expansion as you can.
See, that's my approach, right?
Yes.
I know I want it.
Yes.
Right? But it just makes sense to have, first of all, parallel expansion and 3D expansion, right? And it makes sense Okay, guys, so I just want to add some color here. What Dr. Coppelson is talking about are 2 different methods for essentially doing maxillary expansion. Now, there's a lot of discussion and controversy centered around this concept. But what he's talking about is that there's a joint at the back of the maxilla. So here's the mid-palatal suture. And at the back of the maxilla, where the maxilla attaches to the remainder of the skull, there's another joint. And what he argues for, and what Dr. Casey Lee argues for, is that releasing this joint is actually crucial and can result in a significant difference in the outcomes for those who go through maxillary expansion. The logic is, if you don't remove at the back this joint, you get a fan-shaped expansion like this. Do you see how this is fan-shaped? How it's more open at the front than it is at the back, and it's even arguably not even open at the back? Well, Dr. Casey Lee and Dr. Coppelson would argue that this is suboptimal. But what he's also admitting simultaneously is that, well, actually the data is not entirely clear. And for what it's worth, that's what I've heard now from a variety of expert opinions. Dr. Benjamin Walleen said the same thing. But as you can see, even Dr. Coppelson is admitting that, well, we can't say for sure. But logic and reason suggests that it's better to release the back as well. And then, of course, there's the 3D expansion for cosmetic purposes. This is more what we want, they're arguing. Parallel expansion. That is, expansion that is the same width at the back of the maxilla as it is at the front, and not the fan-shaped expansion. If you just think of a standard pipe or something, right? What difference does it make if you open part of it and you don't open the end of it?
Exactly.
Right?
Exactly. And if you look at the physics behind why maxillary expansion is so effective at decreasing airway resistance, right? Even though we're not really directly operating on the pharyngeal airway, we're changing the way air moves through the nasal cavity, which affects airway collapsibility, right? So having a constrictor at any point within your airway, whether that's in the nasal cavity or in the pharynx, and having air having to move turbulently through that small passageway is where you get that increased negative pressure and the collapsing of the airway. So correct, I agree with you. That's my thinking as well, is that if you have a fan-shaped expansion, you're opening one area, but you're potentially leaving another area constricted, which can be the area that causes increased airway resistance.
I see.
So to me, I'm like, okay, we want to get as much parallel expansion to not only increase that anterior portion of the nasal cavity, but all the way back.
I see. That actually makes a lot of sense. I don't think I've thought about that before, but in the same sense that there's sites of obstruction, let's say throughout the whole airway, some more responsible than others, is it safe to say, like, maybe the confusion is arising because not everyone has the most restriction at the posterior part of the maxilla, and therefore, all those data points make it look like it's not important.
Mm-hmm.
And the signal to noise is it's hard to know.
I mean, it's like, will most patients be better off? Yes, even with the fan-shaped expansion, they're going to breathe a little bit better. But at the end of the day, if you can minimize the places where there's any kind of bottlenecking happening, that's going to be better, right? So, like, will you breathe better if you get a fan-shaped, V-shaped expansion? Yeah, you're going to breathe better. There's going to be an area where the nasal cavity is more open and air will move a little bit more freely. But if you remove any bottlenecking throughout the entire nasal cavity, then it makes sense that that's going to give you a better airway result than just opening one part and potentially leaving a bottleneck in that posterior area.
So, what does the mind procedure look like as a patient? Let's say today someone says, I want to do mind procedure. And let's say hypothetically, even though this is unrealistic, your schedule's wide open and they want to come in and do everything as fast as possible. What does that look like? And how do they, let's take a step back. How do they even know if mind's the right thing for them? Do they have to come here? That's one question. And then, so do they have to come to your office? Is there somehow patients, for example, in Germany can figure out if they need mind from you without coming all the way to LA?
It's a great question. Yes, we have people that come from out of the country, such as yourself. Operate on people from Japan, from the Europe. I mean, from Europe. But generally, I can do a Zoom consultation with a CBCT scan. If I can get some photos of your mouth just to look at the periodontal health and things like that, that would be great. But I can generally make a yes or no recommendation based on a really good history and a CT scan. And then, if we don't have photos, then we'll do the Zoom photos where I have you come into the camera and I try to do as good of an exam as I can of your palate and the shape of the palate and stuff. But honestly, we're really lucky nowadays. CT scans are they provide a lot of data. So you can make a pretty good assessment on someone's transverse hypoplasia, its relationship to the mandible, how wide the nasal cavity is, the shape of the palate. All of that you can see on a CT. So I can generally do a Zoom consultation as long as I have a CBCT scan, and then we can coordinate from there how we get everything else ready to get the surgery done, which usually involves an intraoral scan or some kind of impression of the mouth, so we can design an expander that's going to fit, just right and where we want it.
So, it's my understanding that you're looking for relationships in the skeletal structure to determine anyone's candidacy for mind, right? That's one thing. Mm-hmm. Are there other things you're looking for? Like, something I wonder is, just because someone has maxillary hypoplasia, transverse hypoplasia, does that necessarily translate to mind could be beneficial, or is it more nuanced than that? And some people are restricted, but potentially they won't benefit from mind. And then the opposite of that. What if people are already wide with the maxilla is mind off the table, or how does that work?
So, amazing questions. And, after having done a couple hundred of these, I've seen every iteration. And so to answer your first question is, just because if someone is narrow, do they definitely need mind? The answer is no. Obviously, they need to have some reason for me to alter their skeleton. So, usually it's going to be some kind of nasal obstruction. Some patients with a narrow maxilla will not report nasal obstruction. You'd be surprised. You look at their x-ray, you'd be like, there's no way this person can breathe through their nose well. And they're like, no, I sleep with my mouth closed, I exercise with my mouth closed. I'm like, cool, you are a unicorn. Very, very interesting. But let's say they also have sleep apnea, right? They have some kind of sleep disordered breathing, UARS. Some patients don't even want to snore, right? So those would be a patient that, even though they may not be symptomatic from their transverse hypoplasia, it would be beneficial to maybe do it to decrease their airway resistance, airway collapsibility, and things like that. But if you're just narrow, you're happy with your smile, you're happy with your cheekbones, you don't have any sleep disordered breathing, you're able to breathe through your nose 99% of the time, then yeah, why get the surgery? Now the second question, which is, what if someone appears wide, right? Their measurements fall within what I would consider normal, whether those are skeletal measurements, intermolar width, nasal aperture measurements, things like that. I have operated on those people. They did amazing. So even though I was like, I'm not sure if this will really be life-changing for you, my goal is to always, never oversell, but there are some patients that are obvious where you're like, this is going to be hugely life-changing for you. You're going to be able to breathe through your nose, you're going to sleep deeper and not wake up as much and wake up more refreshed. Like, those are easier consultations because you kind of, they're clear-cut ones. But I've had those ones where the patients, their widths seem pretty normal, but their sleep was bad. Maybe they weren't great jaw surgery candidates. Maybe they weren't recessed. Maybe it was not a surgery that they were willing to go through. And we tried expansion, is like, hey, let's see how you do. It's a very minimally invasive, not super risky operation. Let's just try it out. And they did well. I'd say most patients, if you make them wider, they're going to breathe better, even if they're already normal. If you push them a little bit, extra wide from where they are, even if they are normal, they will still feel improvement, whether that's decreased nasal obstruction and sleep quality improvement.
It's my understanding that aesthetics and functionality sort of travel together in this field. Mm-hmm. Would you say that that's your impression / intuition as well, that if people are functionally deficient, or let me put it this way, if people have stunted craniofacial structure and you treat them, typically do you find that as functionality improves, aesthetics seem to also improve? And this seems like common sense, but I just wanted to ask.
No, it's a great question. Let's just put it this way. I'm writing a book chapter now for a cosmetic surgery book. And obviously I'm more well known right now as an airway surgeon. The cool thing that I've realized year after year after year that's getting deeply more ingrained in my brain is that putting people to craniofacial norms. Now we can argue what craniofacial norms are. I would say they're traditional craniofacial norms that people are maybe taught in dental school are based on norms off of deformed skulls. So people that did not have normal growth because of when these measurements were done and standardized. But in general, if you put people to real normal positions, whether that's transverse width, forward movements, things like that, people look better. They look better, they feel better. I don't think there really ever has to be a sacrifice that's made for cosmetics to get airway results. I think you do airway surgery, right? The movements that you plan on the craniofacial skeleton will give you the most amazing cosmetic results. Obviously, that has to be accompanied sometimes, with orthodontia and maybe a little restorative work, because by the time you expand stuff and move stuff around, like the teeth don't fit into the arch like they used to, because they were used to fitting into a smaller arch. But at the end of the day, if you can get a patient to travel down all those alleys, they look like themselves. They just look like a better version of themselves, and now they're functioning good and breathing good and looking good and feeling good. So, yeah.
So I like to think of this in two buckets. There's always going to be the risk that's outside of everyone's hands, right? And then there's the risks which we can control better for. What are the ones that, like, it doesn't matter who it is or what, they could have infinite experience, but there's these risks.
Yeah.
And then what are the ones where, I don't know, we can control for a lot better? Like, I don't know. Is there anything we can do?
Yeah.
How does that look?
So risks, I would say with maxillary expansion, the biggest risk is going to be asymmetry, right? Whether that's that one side expands farther out than the other side, or the arch expands at a kind of what we call a cant, or so it's like a little cricket. That is generally outside of control, because this is a surgery where, unlike corrective jaw surgery where everything is placed in its final position, and I do that using a virtual surgical plan, custom plates, and I know exactly where that jaw is going to end up. With maxillary expansion, it's more, I'm releasing the sutures and then you push, right? So there's a lot of variables on what that pushing is going to place each half of the jaw, where they're going to end up. The technology is kind of improving and minimizing how bad that can be. One of the things we're able to do now is partially virtual surgical plan these maxillary expansion cases. Look for underlying canting, right? So let's say you're already a little canted.
Do I have that, by the way?
Give me, oh yeah.
I do?
Yeah.
Oh.
Yeah, I'll show you after.
Okay.
So,
I thought I did.
Yeah, so like if you smile, right, if one canine is lower than the other canine, for example, that's a cant.
Okay.
Now, when you expand someone with a cant, you can sometimes not make it worse, but just by increasing the length of that vector, it appears more exaggerated to the eye, because you used to have a small little vector from here to here. Let's say your smile, now your smile's from here to here. So it can look exaggerated, even though you may have not worsened the cant, you just expanded them, and now you just made that canting more visible. So some of the things we're doing now is adjusting for those cants in the vector of the expansion. So for example, instead of putting your expansion screw parallel with your occlusal plane, we can counteract your cant and try to push in the opposite direction that your cant is facing, and see if that can hopefully undo or at least not make your canting worse. So that's new. We're doing that in all my new cases. How effective that is, not 1,000,000,000% sure, but that will be something that we can definitely study and publish on. But I would say that we're moving in a direction where we can make that less common. It's already not common. Most patients will expand pretty symmetrically, but we're trying to minimize the number of patients that can experience an asymmetrical expansion.
What are the generalized outcomes that you're seeing in patients? One little, footnote question I have to that too is that, do you find that there are a lot of patients who are kind of PAP incompliant? They get max expansion and then they become compliant with PAP, and then they're like, I don't want to do an MMA anymore because this is fine.
I've seen those, yeah.
Do you ever see people get cured completely from maxillary expansion? My understanding is that that's kind of rare, because typically a lot of these patients have pretty bad sleep disorder breathing, and it's going to be more than that that's needed. Yeah. Well, what's the generalized outcomes?
Yeah, great question. The generalized, almost 99.9% of patients, huge improvement in nasal breathing. So nasal obstruction is going to go way down. So nasal breathing will improve tremendously, and sleep quality will improve variably. So, like you said, am I going to cure every sleep apnea patient with this procedure? Probably not. Now, if you're on the lower end, maybe a UARS patient, much more likely that you can get cured from just maxillary expansion. But really, we're only treating one variable, right? We're just widening the jaw. If you have multivariable things that can be contributing to your sleep apnea, let's say you're also retrognathic, let's say you're also overweight, then just treating one of 2 or 3 or 4 variables is unlikely to give you a cure. Now, to your question about PAP use. So, absolutely, when you have a narrow nasal cavity, and you have increased resistance to air through your nose, then PAP compliance can become a huge issue. And one of the things patients that undergo maxillary expansion, especially with the MIND technique, I've seen is they can maybe go from wearing a full face mask that was super uncomfortable to going back to using something that just utilizes the nose, which is more comfortable. So compliance rates way up. CPAP settings can come down, right? So maybe you're on really high pressures and that was uncomfortable and hard to use, and now you can drop down and use maybe more comfortable lower pressures. And in terms of quitting PAP, the question of whether or not to keep going, you're a PAP guy, right? So some patients are super compliant with it. They're happy with it. If we can make it, like I said, more comfortable, lower settings, they'll be happy to ride that for the rest of their lives, and I support that as long as they use it every night, right? It's something that if you don't use it, you're suffocating at night, right? But for the patients that are not compliant or can't tolerate it, or that are looking for a cure, that's when we'll start targeting those other variables that could be contributing to their sleep apnea.
So another impression that I've gained, so I talk to patients one-on-one, like I try to help them optimize their PAP settings, right? And some percentage of these patients go through maxillary expansion, and I talk to them all, right? And over time, I get to develop an intuition and understanding for certain things. One thing that seems true, and I'm really interested to hear what you have to say about this, is that so many patients seem to have thought that they breathe good through their nose. They get max expansion because they're just one of those hyper-motivated people. Even though they could breathe through their nose, like, I want more breathing through my nose. And then they say, I can't even believe I thought I breathed good through my nose.
Yes.
Now I breathe good through my nose.
Now I can breathe through my nose.
And do you find that too? Is that
all the time
a reality? Or am I crazy?
Very, very common.
Yeah?
I have patients that were like, I breathe through my nose all the time. And then they get the surgery and they're like, I couldn't. Because I went hiking yesterday and I hiked up a hill and my mouth was closed the whole time. And I can remember I never used to be able to do that before. So yes, there are people that maybe don't realize that they mouth breathe at times. But once that nasal volume exponentially increases, and suddenly air can move through really smooth and laminarly, they realize maybe what they were missing out on. So yeah, for sure I've seen those cases.
And then can we go back to something I left open-ended was, so imagine I'm a patient, I'm in Germany, I think my nasal breathing's really bad, I just went and got my CBCT scan. What's this timeline look like? Let's say they let's just say
6 to 8 weeks.
6 to 8 weeks?
Yeah, just because...
Like 6 to 8 weeks, to see you for the first time? Or are you saying...
yeah.
Like, what does the whole thing look like? Starting at like...
I don't know how far I'm booked out, probably a couple months at least, just to make a consultation. So, do a Zoom consultation as long as you have a CBCT, so I make sure you have a CBCT ready to go. And then after the consultation, if we deem you a candidate, it's usually about 8 weeks or so until we can do the surgery at the earliest.
Okay, and then they get the surgery, and then what does that look like?
So usually patients will stay in town for like 3 days at the minimum. Usually we'll do it like on a Thursday, Friday, and then they can leave like Monday morning after a quick follow-up, right, where I look at things. At that point, we can generally monitor the patient remotely via Zoom follow-ups, and then I have patients text me pictures. So a picture of their smile, picture of their palate, and I can assess how the expansion's going, how the palate looks, how the screws look, how far they've gone. Are they expanding too fast, too slow? I can keep like a visual diary of things. And it's very rare that a patient ever has to come back for any issue throughout the expansion phase, but then obviously they'll have to come see me again when it's time to remove the expander arms if they can't get someone to do that locally. And then at the end of the consolidation phase, so after you're done expanding, we have to hold it until bone fills in so that expansion becomes permanent. So once that consolidation phase is done, then they'll come back for a quick appointment where we remove the TADs, which are the screws that we use to anchor in the MARPI.
And what's the deal with the whole orthodontics thing too?
So yeah, we're moving the jaws. The teeth follow the jaws. So orthodontia is generally required to not only cosmetically fix the bite from the expansion, but also to fix some of the compensations and camouflages that have happened. The traditional textbook transverse maxillary hypoplasia patient is supposed to have a crossbite, right? Which basically means that your lower molars, let's say, stick out farther than your upper molars. It's rarely true. Most people with transverse hypoplasia do not have a crossbite because what they will have is compensation. So their upper molars will be tipped out buccally, their lower molars will actually be tipped in lingually, which is bad for your tongue space. So orthodontia is also beneficial or required in these cases to upright the lower molars so that by the time we are done orthopedically expanding the top, right? So orthopedic bone expansion on the top, orthodontic uprighting on the bottom, and then your teeth will match, your bite will feel good, and it'll be functional. So yeah, orthodontia plays actually a huge role in these cases.
I asked you over Zoom recently, what's the deal with the turning rate? And how should it be fast, slow? Does it matter? What is as I understand it, the evidence is very limited at this point.
It's very limited.
But it's saying something.
It's anecdotal, but I would say powerfully anecdotal, in the sense that I've done a lot of these cases. There's other providers in other parts of the country that all have done a lot of expansion cases, and maybe different populations. I tend to get, I guess more adult, difficult cases. But in general, what I found, we used to go very fast, maybe 2 millimeters a week. So very, very fast in the old days. Most of those cases were fine, no issues, nothing, nothing weird happened by expanding that fast. The reason I have slowed down is because there is a maybe 1 in 10 case where you're moving, let's say, at 1 millimeter per week. Or at some point in the expansion, they're already split, they're already, let's say, expanded 3 millimeters. It's not like anything we're waiting for things to crack open. And they will experience pain, sudden pain. Variable. Sometimes it feels like it's a tooth, sometimes it feels like it's a cheekbone, sometimes associated with a noise like a crack. And in the beginning, that obviously concerned me. I'm like, come in, I need a CT scan, I need to look at everything, I'll make sure you didn't break a tooth or whatever. And I look and everything looks fine, and do another 12, then have another patient that happens to. This time I'm less nervous, but I still bring him in and check. So, where you get to is where you get to, right? So I'm like, and in those cases, the way we treated it is we paused, waited for everything to settle down, and then we started expanding. It started expanding at a slower rate, and then they were okay. That pain never returned. So I just kind of, from that point, started slowing down my turning rate a little bit, and I just run into that so much less frequently. And the results, obviously there's no double-blind placebo-controlled trial, but they seem to do just as good. They get to that same final destination of where they would have gone to. Takes a little longer, obviously, which is maybe annoying for the patient in that regard, but there's less of those, flare-up of pain or things like that can happen during the expansion phase when you go at a slow rate. So I have some patients that are like, I don't care, I just want to get there faster. We can go faster. I'm not morally opposed to going at what I used to go out, like let's say a millimeter per week, but now I prefer, I'll push a patient to go to 0.5 millimeter per week, but you know, it's a team decision, right? So it's your body. I think we're gonna move towards slower just because it's more comfortable. There may be some better orthodontic, like less orthodontic complications by going slower. But I think airway results, I think they're going to end up being pretty equal. I think it's just the ride will be a little bit smoother the slower we go.